Thank you. Thank you to Manos for the invitation. Very beautiful congress. Every year is better. So, just a little introduction. The risk factors for arthroscopic Bankart repair failure are granule bone defects, big granule bone defects, capsule tissue deficiency, shoulder repair laxity, and contact sports. Now, just to tell briefly, it's very difficult to calculate the bone loss. And the future is we have to wait the 3D. You see, this is a new software that automatically change 2Ds in 3Ds, and you can have directly printed the bone loss. And maybe in the future you can use this piece of bone custom made on the defect. Then capsule deficiency. If you have a capsule deficiency, you have no good tissues anteriorly, Bankart repair is going to fail. Now let's talk about hyperlaxity. This is a guy that has a general hyperlaxity, but is asymptomatic. No pain, no dislocation. Then we think that, as very in a wonderful way explained Professor Castagna, you have to make a good diagnosis. We think that it's a selective shoulder hyperlaxity in the family of the hyperlaxity, and it is acquired hyperlaxity for center sports, or constitutional hyperlaxity, and this is very frequent, just on the shoulders, and it's bilateral. You have to make the diagnosis, a good diagnosis before choosing the. And we think that in anterior inferior instability, many patients have a shoulder laxity and have a predisposition to anterior inferior instability. And then we have to do specific tests, sulcus sign, everyone knows it. That means that there is an elongation of the coracohumeral ligament, as you can see. So there is an elongation of the coracohumeral ligament, and the head goes down, in an abnormal way. Then there is another test that we always use before choosing the operation, the Coudan test, that shows you that you have a problem in the anterior capsular portion. And the anatomic pathological problem are usually you find a thin and redundant anterior pouch. Here, if you do a Bankart repair, you're going to fail. Or you have an apoplasia of the anterior labrum, or as all these bunch of guys told in the past, that you maybe frequently have an hyperlaxity or an elongation after repetitive trauma or constitutional of the subscapularis tendon. And so we do this text every time when we go in the shoulder. We see that here there is an elongation and hyperelasticity of the tendon, and here you don't have it. So there are different types of subscapularis behavior. And then the other when the Bankart can fail, when you have when you do a contact sports, high risk of failure only with the Bankart repair. So, as Professor Castagna told before us, you have to do a correct diagnosis. Ask the patient when he has the first trauma. Do a correct clinical evaluation. Try to measure the bone loss, but I told you right now it's very difficult to find granule bone defects or if that humeral is off on track. It's very, very difficult. And then find the right indication. According to Lenny Johnson in 1986, he told in this book that when you have a bad capsule, you could have an help from the subscapularis tendon doing a tendinosis. And he used to do it with these anchors, but these anchors used to be staple anchors from Macar instruments, and they failed. But beside the staple were failed, the shoulder was stabilized. So according to it, I thought 10 years ago to do the same thing using modern anchors, and grabbed, after the Bankart repair, the upper third of the subscapularis tendon. With this kind of, this is a push lock, but you can do it with new generation suture anchors. How to do this, the ASA? You have to do after the Bankart repair, the granule bone hole has to be slightly over the top of the granule edge. You have to penetrate the tendon right there. at least 5 millimeters inferior from its upper border, slightly flush to the glandular surface in your mediolateral position. You have to be very careful to do these steps correctly. This is a cadaver specimen. This is in normal surgery, you see. You grab the upper border of the subscap with the tape. You have to use a tape, not a normal suture. And then fix the tendon. When the tendon is elastic, you have to fix it in the north. So more in the north, at 2 or 10 o'clock, north of the equatorial side. So you can have a closure of the interval. So here is from up, you can see the banker repair in the inferior and the tenodesis in the north. And the head is recentered, before and after. So, little consideration. We have to study more how this technique is healing, but we believe that ASA procedure may strengthen the coracohumeral ligament and improve biologically the healing process of the banker repair. And we think that reduces, especially in shoulder relaxed, the volume of the capsule, and it creates a stiffness, a little stiffness of the shoulder and more strength. This is a work done from my partner Raffaele Russo on 11 cases before an ASA, and he found that you have a reduction of the volume of the capsule before the surgery, and you have a coma sign on where there is the tenodesis. This is the second look. It's a guy that had an ASA after 2 years of trauma. He accepted to have a second look. He had more than 50 dislocation, no big bone loss, but absent labor, bad capsule. So we did the procedure, the ASA and tenodesis, and I can see quickly, I can show you quickly the second look. You can find a very strong labrum. Oh, this is before the surgery. Now very, very strong labrum, very strong scar tissue on the north. Here you see it. You see this scar tissue very strong, and this, you see. So we did a biochemical study, and our conclusion was that the ASA stabilized much better in anterior and anterior translation respect the banker repair. These are other guys that tried this operation in another way. So when do you use it? Hyperlaxity, capsular deficiency, and glandular bone loss less than 20%. This is a problem to calculate this. And the recurrence rate of ASA plus banker repair is equal when the indication is good of the Latarjet. Important, there is no compromission of the external rotation. And we think that ASA function in the opposite way of the remplissage, because it pushes the humeral head behind, and the remplissage pulls the humeral head behind. So it's an opposite action, but you address the problem where it is, in the anterior side, not in the posterior side. We are publishing another article to show that there is no problem with arthropathy or osteoarthritis. And so our conclusion is that we should not be afraid anymore to use this piece of tendon to help the banker repair. And so this is an opportunity to fill the gray zone between the Latarjet and the banker repair when you don't know what to do. This is a guy that has been operated after 5 months. He had 5 dislocations before. This is another guy that has 3 dislocations, and now after has at 5 months, is one of our champion. And 800 of patient has treated with ASA in different centers. And they are doing even in China, little bit modified, but the results are very good. And so, why for reason that we should do ASA, is not, this is our opinion. Low learning curve, low recurrence rate when the indication is good, low complication, I could see no complication, a high opportunity for new surgery if there is a failure. I will invite you in Texas at the ANA procedure and at the ANA meeting where I want to present our results. And thank you very much.